Good evening, dear all. I actually have to say something that we didn't realize that we have passed 1 year, and we are going to have our first anniversary MDM on the next 7th February. We are going to have it on 7th February. Usually we have 2 weeks gap, but this time the next MDM is on 7th February. So that I'm announcing in the beginning itself. And believe me, I did not realize that it was so fast that we finished 1 year. And do join us for that, because we might invite everybody. We are going to invite everybody whomsoever has in a way contributed directly or indirectly for making this happen. Thank you so much for all of you who have joined today. And we have got our 5 cases. Once again, Bhavin sir is our radiologist, Mithun is my rheumatologist, Prahlad sir and Rajan sir as well as Murli sir are our pulmonologist expert. One more person whom I have to appreciate is Prakhar, who is becoming our regular presenter. Thank you so much for contributing, and your cases are very interesting. That's why I'm saying that. And
Thank you.
actually, Amila was the one who was going to present the first case, but I could not find him. So, Amila, you there? So
He's
I
just
will,
joined. Yeah.
yeah, I will just share the screen of Amila's case as a first case. So you able to see my screen, Amila?
Yeah.
Yeah, just go ahead. Thank you.
Thank you. I mean, thank you for the opportunity. So this is my 47-year-old male. He's from the southern part of Sri Lanka and presented with hemoptysis for 5 days. But he further complained of progressive shortness of breath for about 8 months duration. His MMRC2 is not much bothering for him. He denies any history of appetite loss or weight loss or any night sets and all, and he did not have any kind of history of exposure to TB and all. But he was treated for pneumonia when he presented with the same symptoms about few months back when he was working in South Korea. He was basically working in a steel industry in South Korea with some significant exposure to fumes and all and heavy metals. He was engaged in this work for about 3.5 years, and he has a significant exposure to poultry as well. That is before that exposure. So there are two exposures to steel as well as to poultry. Next slide, please. So his examination is saturation was all right, 97% on air. And on examination, there are some crackles, fine crackles on the lung base. But the rest of the examination was fine. Next, please. Yeah, the counts are unremarkable and inflammatory markers are normal. The sputum cultures are negative. We examine for tuberculosis as well, and AFP detection was negative. Gene expert not detected, and the mount was negative. Next, please. Yeah, interestingly, is autoimmune serology actually is ANA. Theta was actually, I didn't mention that, but it's 1 in 80, and the nuclear pattern is not a very high theta, and cytoplasmic pattern was positive, but it was not a very high theta, 1 in 80. So therefore, we didn't go for these extended panels. Next, please. His lung functions is moderately restricted, as you can see here. FEC is about 69% predicted. FE1 is 68%, and the walk test about 332 meters without any desaturation. These are chest X-ray actually that I'd like to, kind of get our expertise opinion, but there's a left apical cavity, a thin wall cavity, I would say, and with some reticular opacities in the lung base. So then we'll discuss the radiology HRCTs of this gentleman. Thank you.
Yeah.
So can you all see these two scans? I think they should
Yes.
be clearly visualized. Yeah. So the one on the right is 5th September. The one on the left is 20th November. Both of them are pretty much the same. So I'll start from the top. One of the things that strikes us is that left apical, cystic lesion with moderately thick walls. It looks like a cavity. It has changed between the two scans. It's kind of reduced in size over 3 months with a little bit of fibrosis. But I think that's not the point of the discussion. If we see here, we are looking at reticular opacities, subpleural involvement, And then as we keep going down, again, we'll come back to this. That's a super added complication. We come down and again, we see these reticular opacities. We start seeing some honeycombing here. There's no significant change between the two scans. A lot of honeycombing, traction bronchiectasis, and then there's exuberant honeycombing on the left side here, kind of symmetric disease, cystic lesions here, and then honeycombing, traction bronchiectasis, some cystic change in this area. So this is like a UIP-like pattern, but basically it's just classic connective tissue disease, ILD, um, with some form of spatial temporal homogeneity, exuberant honeycombing, all of that with no significant change between the two scans. Now, apart from the left apical complication, we also have this problem here where, in the anterior segment of the right upper lobe towards the inferior aspect, you've got a focal opacity. The first scan shows subtle air bronchograms here. The bronchus here is a little occluded, so I'm not sure if there's mucoid impaction here or a small endobronchial focus that is causing this appearance. But that's pretty much what it is. It's not particularly hyperdense, so I don't think we're dealing with an ABPA-like situation. But this bronchus here gets occluded by this nodule. Then we have the rest of the post-obstructive consolidation or opacity here. So background ILD looks CTD ILD, one focus here in the anterior segment, right upper lobe, and then this left apical cavity.
Uh, Thank you, Dr. Jankar. I'm just wondering, actually, do you have any differentials for the cavities? Is it, do you think it's, a form of TB, or do you think it's more towards fungal?
So I would think it's a post-infectious phenomenon, but I don't see any evidence of otherwise fungal disease. The only thing that was worrying is if you see this nodule here on the second scan towards the inferior aspect, maybe we can look at this in the coronal plane a little better. Let me just get rid of this thing here. This is what we call a scab sign, where this could be a secondary aspergilloma or a chronic cavitary pulmonary aspergillosis, which these are the things that then fall off and then become fungal balls. But I mean, it needs workup with a bunch of tests to prove it. I don't think on the radiology we can convincingly say what the organism is. So.
You
In
have
fact,
no
now that we've looked
microbiology
at
in?
coronals, just look at the straight edge sign here. It's so beautifully visualized, the sharp edges
All right.
of
Yeah.
the disease. Yeah.
You have no microbiology in, Amila?
No, we do have, I think, next slides, because we
Sure.
performed the bronchoscopy and all. Yeah, thank you, Dr. Jankaria.
Thanks for everybody. Muting it.
So yeah, so at the end of the CT scans, we were worried about particularly, atypical infections, including tuberculosis and fungal infections, as Dr. Jankaria said about these aspergillus and all. So we performed serum as well as bronchoscopic evaluation. So this is the serum evaluation. The serum aspergillus IgG was negative, and we did serum galactomannan was margin elevated, and we did a bronchoscopy. We found quite a lot of mucus plugs in the trachea, and main carina was normal. And in the right upper lobe anterior segment, that we saw there's a complete occlusion with the mucus plug, as Dr. Shankaria correctly said. And also there's a mucosal bulge as well. We took some biopsies from this area. And the histology, it was non-significant. There's only benign bronchial epithelial cells, and they have stain for the fungal elements, which was not there. But the fungal culture revealed this trichosporin, and we discussed the mycologist, and that was not very significant. They say it is, but even though it is kind of grown in the biopsy, but they were not they say it's more likely to be due to contamination and all. The bronchial wash was positive for galactomannan, that is 2.87, and the bacterial culture was negative, and the cytology was inconclusive. There's no malignant cells. And next slide, please. So yeah, so basically currently, I mean, because even though this patient has breathlessness and we couldn't treat with immunosuppression because of this ongoing infection, and we were concerned about that whether it's a because of the fungal etiology, and we have, I think, sufficiently excluded tuberculosis here, and started on voriconazole, and he's at the moment on voriconazole. There's no hemoptysis, but his disease is progressing. I mean, he's actually is losing his weight now, and also that he's becoming more and more breathless. So my concern is actually that I mean, overall diagnosis of ILD I mean with this ongoing infection, and I'm not very sure whether we are dealing with something else like another atypical kind of infection, maybe like a more complex fungi like mucormycosis, something like that, which we might have not detected. So they have to kind of do the complete workup again, whether we have to go for a surgical biopsy here. And then how do you manage this ILD with this ongoing infection? That is a major challenge that I'm facing at the moment. So at the moment, so he's on voriconazole, but I still feel that, I mean, we have to do a further workup, maybe get in touch with the surgeons to take a biopsy from the region, and then from this consolidation, the upper lobe actually. I'd like to kind of get your expert opinion on this this challenging situation. This very common in our part of the kind of world. Actually, there's same time there's ongoing infection, plus there's a condition that which requires some immunosuppression.
Okay, Prahlad sir, yeah.
So his presentation is like hemoptysis, so that is
Hemoptysis, yeah.
yeah. So that can be explained by that cavity with the early aspergillus probably. Maybe that is the reason. But you know, lung disease, the interstitial lung disease, what is the cause? They have CTD-ILD, but he has no clinical features of CTD-ILD. I feel you have given history of 6 to 7 years exposure to metal fumes in steel factory.
Yeah, that is the main exposure.
So that the metal fumes are very vague, but you know, in steel factory, I had seen a more or less a similar patient, and when we asked him to give a photograph of that steel factory, then there we could realize that steel factory, a lot of things happens from the raw things comes to the actually steel is made, where they are all exposed to nickel, chromium, or even the cobalt. Okay, so those things they are exposed, and they all can give ILDs actually. Okay, so I feel the ILD reason is the honeycombing and cystic areas. Basically, could be related to some of the gases which are he is actually exposed in the steel factory. Okay, so iron does not give much. It gives hydrosis, but the partly a combination of cobalt and nickel and titanium, all those things, gases may be there. I don't know exactly what will be there, but these are all can give rise to interstitial lung disease. Aluminum gives basically the more of a cystic lung disease. So the cause could be occupation, and which can we have to guide them regarding guide him also regarding whether to get occupational therapist should be involved, or somebody should be involved where his the current work probably we have to shift, because that could be one of the causes if the immunology.
He's no more engaged in the same occupation. That basically is unemployed. Now he came back to Sri Lanka. He was working in South Korea, and these all these metal exposures, and he came back with this hemoptysis history, and then now there's no continuous exposures.
Was there Amila, how long was he working at this steel unit?
About 3.5 years.
So that's not very long. I'm just trying to see if and he's 47 years old.
Yeah, he's young.
When did he stop working at the steel unit?
So it's about 6 to 8 months. I mean, he's been stopped working. And
do we have a pre-employment X-ray or anything?
No, he was a completely healthy person before that. We don't have any X-rays now.
And he hasn't lost much lung function either. He's not desaturating, but his vital capacity is 69%.
Yeah.
You don't have a DLCO, right, Amila?
No, actually, no, at the moment, no.
Okay.
What were his previous occupations?
No, previously he was involved in his poultry industry. He had a chicken farm, and then
Chicken
on
farm.
yeah. So then only he moved to Korea. So
And chicken is one of the unusual birds that doesn't cause HP. So anyway, this doesn't look like HP, but it's one of the birds that has very low association with HP.
Mhm.
So I
And
don't know
could you
whether we
use
would do a biopsy here. It's not classical honeycombing, but I think I would be inclined to do it considering his age, Amila.
Basically, honeycombing is proximal rather than distal, na? Bhavin?
It's both. It's that typical honeycombing you get with CTD now.
Okay.
Exposures can sometimes simulate this and cause all kinds of weird patterns. So it is possible. But I would still rule out all the, despite the ANA, run the entire myositis profile. Like
Yeah,
this
yeah.
is
I was just going to say that it looks so typical of CTD.
sometimes the ANA is very deceptive and maybe it's worthwhile doing that. So, if you don't find anything with a deep dive, then I guess it's exposure related, but we should rule out everything.
And if
Yeah, I
everything is
I'm so
negative, maybe a biopsy then, Amila.
yeah.
Would you prefer kind of extended autoimmune panel prior to the biopsy, or I mean, because
Prior. Because if something comes in strongly positive there, you can avoid a biopsy.
Mhm. But still this weird consolidation, that's a concern. I mean, that we might not be able to
Yeah.
get help on that, isn't it?
Yeah, that's the tricky part. That's why your microbiology, trichosporon, I know you said maybe a contaminant, but it's, hemoptysis, cavity, little difficult to believe. I think, and what's the gap between the two scans, Amila?
It's about 3 months. Yeah,
3 months. And voriconazole is just started, right?
just started after the second scan, actually. Yeah.
Second scan. So
Yeah.
give it 4 to 6 weeks and see what happens, with the voriconazole. How long do you plan to give voriconazole?
So I plan to give about at least 2-3 months at the moment, and he's already received about 2 months. And my concern is, and now he started losing his weight, and his breathless is getting
Sure.
worse. Well, and the treatment, I mean, at least the hemoptysis has been settled now, but the overall, I mean, he's deteriorating.
I think Mithun, yeah. Mithun,
what,
one more comment from my side. So, want you like to know what was the ESR and platelets and CRP? Because I also feel why don't vasculitis? Something needs to be ruled out. Now, such a cavity, hemoptysis, and all. What was your doubt, Mithun?
no, I was asking about the ESR and CRP.
Yeah.
The
ESR
present.
is around 20 and CRP is less than 2. That's normal.
Oh, okay. Okay.
Very bad. Because he should have some infective response. Yeah.
In Professor Ethol Wells's absence, I'm going to channel Ethol and
Yes.
say maybe his initial lung function was much better, well over 100%. So 70% may represent a considerable decline.
Yeah.
He is breathless. That's what Dr. Miller tells us, that he's becoming more breathless. So I think his initial lung function may have been much better than, the predicteds would tell us. It's classic CTD-ILD. I mean, Bhavin has shown us all the findings. I think we're dealing with two pathologies here. One is the infection. Certainly TB, in India, we would say TB first. Cavity like that, fibrosing, becoming smaller. Secondly, infected, mycetoma developing within it. So the absence of the Aspergillus antibodies doesn't mean, rule it out. So let's treat the fungal infection, do the non-invasive workup. I completely agree with both Sujit and Prahlad that we should do the non-invasive, but I think a biopsy will be indicated at some point. I'm only wondering whether Vori is the drug of choice or we should move to posaconazole. Since the Aspergillus is negative, keep other fungi in mind also.
Yeah, that's also my worry, whether there's any mucormycosis or something like that involved in. And yeah, I would kind of thank you so much, and it's very helpful because I have to discuss. I'll discuss with him again that I also feel that biopsy might be necessary in this case and to rule out. And meanwhile, we'll work out for these extended autoimmune panels and all. And yeah, I think again, because we saw a lesion, obstructive lesion in the right upper lobe, and there may be a place for biopsy, I think. Yeah, thank you so much. It's very helpful. Thank you.
Thank you. Thank you, Amina. I'll move on to the next case. I think, Prakhar, second case I will be presenting, and I'll give you 3 and 4 for your case. Okay?
Sure, ma'am.
So I believe this will be the simplest case of today's because I know what other 2 cases are. So she's one staff of Amrita whose mother came to me. She's a 59 years old lady who is a housewife. She lost her husband recently, so she had some uh, emotional issues also. And the doctor who has referred her in somewhere in September, October, but she could come to me only 1 month before. So she is 59 years with history of hemorrhoidectomy and other things. But in March 2024, she was admitted with pneumonia, which was labeled as a viral pneumonia, and she was treated with oxygen support. She didn't require ventilator that time. That time CT scan was taken. And October 2024, that was the time when they diagnosed that she has got some cardiac problem and she was started on amiodarone. And that is the time when she had some exposure at home also because there was some renovation going on. And in October 2024, she came again to the same doctor, previous doctor, with exacerbation of shortness of breath, and he repeated a CT scan again this time. This time also he found the similar finding, and this is the time when he decided that he'll give her steroids. And she received some 30 milligram, 20 milligram, 10 milligram over 1 month, and they stopped it on the basis of diagnosis of HP. That is what the diagnosis was made by. However, I didn't see the March CT scan, but I was told by that doctor that doctor told both the CT scan were almost same. So when she came to me, she has got dyspnea on exercise for almost grade 2 for last 1 year, occasional cough, scanty expectoration, but predominantly dry cough. She has exposure to grain days. So what they are saying is this is a particular season. That was in March, that harvesting or whatever they say, that is what was happening in her house, nearby her house, because they have got farm and all. And that is the time, every time whenever they are doing this particular work in her home, she will develop breathing difficulty, which was labeled as asthma, and that is why she was on inhalers. She has some Zika symptoms, but not predominantly any connective tissue disease profile symptoms were present. 97% on room air, 69 was her heart rate, and BP was normal. This is the ANA profile which is done in my hospital. Mithun, anything significant here? Nothing, right?
No, nothing.
Nothing. And ANA was immunofluorescence, ANA was negative, RF was negative. OTPT, you can see mild derangement, that is important. So I have written it in red. ESR was 28. Now this was her myositis panel. And when I examined her, I think Mithun also, you also have examined. Now, Mithun, you found there was some mechanic's hand, right?
That patient. No, okay,
Yeah,
okay.
yeah. So you also
Hey,
found,
sorry, are you showing a presentation?
yes,
I cannot see it. Can everybody else see it?
Yeah,
Yes,
fairly
yes,
clear.
yes.
Yes, we can see it, Bhavin. I think
Okay, I don't
maybe
know where it's gone for me.
oh,
This is so weird. Okay,
you are
no,
not,
go ahead. Then I'll
yeah,
I'll
yeah,
search for it. Yeah,
yeah,
that's
yeah.
fine.
So she had PL7 and this PL12. Mithun, because since you had seen the patient, do you think this particular PL7 profile with her finding was significant?
What was the CPK, ma'am? SGOT more than SGPT when you have
CPK
that?
was 160. Yeah, I did it after you ordered it, and we did it, and it was 160, 160.
160 is almost normal.
Yeah, it was not very high, right? And mechanic's hand, but they are telling her hands were always rough. But other than that, did you find no other
No, mechanics hand is usually tricky. Those who are working hard, like those who are doing
farming and
routine
all? Yeah.
farming, they will have the typical mechanics
Yes.
like hand. This also look like that only. And this
Yeah.
antibody is only low titer positivity. As always, we tell difficult
in
to interpret
myositis.
this 1+.
Yeah. Nothing significant. So mechanics hand, I took second opinion from him. This is her pulmonary function test, which was done. From 98, she desaturated to 88%. However, she walked for 300 meters. DLC of 36, KC of 49, and 54, 53% FVC and FEV1. And with that, I will stop sharing my screen and Bhavin sir can take. I had differentials of amiodarone-induced ILD with HP.
Okay, so you may think this is a very simple case, Asmita,
Yeah.
but I'm having a lot of trouble with this one, all right? So the bottom three images are of 5th October, and you can see the lung windows are all in expiration. So now that is a challenge by itself. And so to me, the main finding is perhaps air trapping, but I don't have an inspiratory-expiratory pair, some subsegmental atelic basis in the lower lobes, and whatever has been called ground glass, and I'll come back to why I don't think that's ground glass, is just what it is. Now, the finding is, you see the MPA diameter here is 34 millimeters. Now, CT is not very sensitive for pH, but it's specific. I've got an PA to AA ratio greater than 1. So there is pH, there is pulmonary hypertension, uh, but there is no obvious cause for it, at least in terms of shunts or any of the group 1, group 2 causes that we would be looking for. But the LA is a little dilated. I again don't know why. You can see the left atrial appendages. I'm just running through the various findings that are there. Then we have the January 25 scan, and you have an inspiratory-expiratory pair, which is very useful because then you can see that there is air trapping in the lower lobes. There seems to be what looks like, again, this is not fully inspiratory. It's like a mid-inspiratory scan. And what looks like ground glass, if you see on the expiratory scan, all those so-called areas of ground glass are showing increased density, which means that if you see increasing density from non-dependent to dependent and an increasing whiteness on expiratory, that means it's most likely normal lung rather than lung involved by abnormal stuff. And so this basically just looks like patchy areas of air trapping with normal lung. And I still see that, there is definite evidence of pH, and there's something off with the heart. The LA is a little too large as compared to what it should be. And that's pretty much it.
So you feel this is small airway disease?
I think it's small airways, there's pH. I don't think the small airways is that much, at least on the CT, to account for the pH. So I wonder if there's another cause for the pH. Maybe it is a group 1, so then it becomes a PAH. I have another issue here, and Murli, I remember last 2, 3 meetings back, you said that we shouldn't use the word PAH because a whole bunch of people seem to be using it for anything that is pH. Did you say that? You said that, isn't it?
Yes,
But it's rampant. I'm just seeing it all across board everywhere. That, now that you mentioned it, I realize that PAH has become the default term for pH rather than it just being the term for group 1 pH. So I don't know what we can do about that. But anyway.
we can soldier on.
Yeah. We can teach every time when people are doing
Yeah.
mistakes. Yeah. So that was the only doubt about this case, because the daughter is really concerned, and she is. What was my problem was I was having doubt about amiodarone because in March when she presented with similar finding, that time only amiodarone was started, so it was unlikely to, because of that, as March was the first presentation and October again the presentation happened, and it was hardly 6 months or something since the time, and then she came to me late because of some family problems. So let me just finish my presentation, or we can move to the third. So this is what we had, that is it small
What was
airway
her
disease.
echo like, Smita?
Her echo was very bad. I think she had significant left ventricular issues. I'm sorry, I forgot to put it, but pulmonary hypertension was there or not, I'll just check in between and will tell you. And then do I need to do biopsy? You sure it is small airway disease, right, sir? Because she doesn't have any other symptoms at present. I have started her on simple inhaler and short
Definitely
course of
not
steroids.
do a biopsy
I mean, I'm
unless
sure there's
Prahlad
no
and
ILD. I
yeah.
don't
Yeah.
know what else is going
But
on.
I would
Okay.
look at that echo carefully and decide whether to treat her with steroids, inhalers, probably, and or move to a right heart cath if we are not getting a good response. Murli,
For pulmonary
blood?
hypertension.
Yeah.
And a coronary angiogram,
Yeah.
and perhaps a sleep study to look for sleep apnea, because this looks more like diastolic dysfunction, pulmonary hypertension group 2, and some small airways disease which you're already treating anyway. So I would look very carefully at the heart, and apart from a right heart cath, maybe even consider a coronary angiogram.
Okay. I have given her a cardio consult and they will be seeing them also. And yeah, she had amiodarone induced hypothyroidism also. So that is one person is taking care of that also.
Do we have a BNP, NT-proBNP, any of those?
I didn't do it. Do we? Because the CT scan was not showing bilateral effusion or cardiac failure kind of thing. And there was one cardiologist who was looking after. So I didn't use much brain for cardiology. If you think it because of
I
pulmonary
would,
hypertension. Yeah,
I
okay.
would get a baseline done,
Sure.
Asmita, for
I will do that.
before meeting the cardiologist or just after meeting the cardiologist.
Yeah, we will do
The
that.
cardiologist may ask for it anyway.
Yeah, I'll do that. So
May
now,
not, Sujit. They are delightfully blasé about diastolic dysfunction.
yeah, they are very happy
That's
labeling
true.
it as a pulmonary case most of the time. Yeah. So
I
moving
think
on to the third case, this is Mr. T, I believe, and yeah, Prakhar.
I just want to ask regarding that considering the diffusion is so low and your small airway disease will not give so much amount of pulmonary hypertension. I think it's probably a pulmonary hypertension is a diagnosis.
Yeah, yeah.
Maybe around 6 minutes walk distance also showed significant.
Yeah, significant
Yeah.
desaturation,
The issue
severe
is,
desaturation.
Prahlad, is it pre-capillary or post-capillary? That's my question. What do you think?
Unless you do the cath, how will you tell?
Yeah.
I will ask whether she will be fit for that because she is
Yeah.
already on amiodarone and also maybe it might be tricky situation for cardiologist also. But I'll speak to them and anyway they will be more than happy that she doesn't have to take steroids.
Why should it be tricky on amiodarone?
Because I don't think they want to stop it and she has I'll tell about her echo and why is she on amiodarone because she had significant cardiac issue. That is why she was started. Not only amiodarone, she is on many other drug. I have just highlighted amiodarone. That's
No, there's
okay.
no parenchymal lung disease,
No, parenchymal.
Asmita.
Yeah.
So
Yeah,
I
yeah.
don't think there's an issue with continuing amiodarone. Low KCO, low DLCO, desaturation, either severe small airway disease or vascular.
Scan does not so severe small airway disease.
Right. That's right.
Yeah.
That's right.
Sure. Okay. Prakhar.
Okay, ma'am. Good evening, everyone. So we have a 56-year-old male who's a farmer and has been a smoker and now presented with a shortness of breath since 3 months and dry cough since 1.5 months. And his shortness of breath had increased over the last 1 month. It's a typographical error. He had no systemic symptoms, no CTD symptoms per se, and among exposure, just about some cooler use, nothing else. He was mildly hypoxic on ambient air, had grade 3 clubbing. Respiratory system had bilateral fine mid-inspiratory crackles and occasional inspiratory squeaks. Musculoskeletal was normal. Among labs, the relevant ones were that CRP was high, as well as ESR. NFC showed some amount of capillary density decrement and tortuous vessels along with avascular areas. Echo was normal, no pulmonary hypertension was observed. We did a BAL for this patient and rest everything was negative. His TLC was, however, 140 with a monomorphic pattern and cytology was again nothing contributory. We as well as did a cryo TBLB for this patient. Ma'am, can we have CT prior to this?
Yeah. Bhavin sir.
Same patient. This is the same patient who has 2 scans.
Yes. He is the
9 days,
one.
8 days apart.
No,
right?
no. I
No,
think this is Mr. T, and that was a female, sir.
Oh, okay. So Mr. T is 4th case actually.
Okay.
Sorry, that's the 17th December compared with the 10th January, correct?
No, sir.
That is the That is with you, na? Sir?
This is you.
No. So one was a lady and
And
one
one
is
was
a
a
male.
man. So this is man.
So man has a PET CT also, correct?
Yes, sir.
Yeah.
Same patient. So it's 17th December is the first scan,
Hmm.
and there's a PET CT of 10th Jan.
Yeah.
Okay.
Two CTs for both the patient. Yeah. Maybe.
Hai na? Prakhar,
Yes,
am I getting something or
no, sir.
wrong?
It's correct.
Okay, fine. So at least we've got that sorted. It's just that, yeah, actually the easier way is one's a man, one's a woman. So, okay. So this is where we are with the first. Let me just align these. So we have the 17th December in the bottom row, 10th Jan is the PET scan. So again, little, I guess, patient's breathless. So mid-inspiratory scan, start from the top, a lot of reticular opacities, a lot of traction bronchiectasis distally, blurring of images. Again, you've got these cystic areas here. We come further down, cystic areas and honeycombing. And you said he was a smoker, right?
Yes, sir.
What was the smoking index?
So he had a 400 of back here.
So then basically it just fits into a smoking related ILD with a bunch of things. I think there's an UIP pattern, there's some little bit of an atypical pattern. I think there's a superadded respiratory bronchiolitis, and a lot of what looks like ground glass here is perhaps either a superadded inflammation DIP or it's just a function of a mid-inspiratory scan. That I'm not able to sort out. And then when you look at the rest of the mediastinal windows, the MPA diameter is okay. There's mediastinal widening of fat as if he's been on steroids for some time now. I may be wrong, but whatever. And then everything else is okay. And then when you look at this scan, which is now about 3 weeks later, there's no significant difference except that we see more increased density in the bases. But again, it's a more expiratory scan. So I always get a little wary. But there's a PET. And so if these areas of increased density were significant, they would have lit up on PET, which they haven't. There are some nodes which are not significant, be secondary to the underlying inflammation. So basically, smoking related ILD, multiple manifestations. That's my take on this.
Okay, sir. Because we did PET after having received our biopsy report.
Yeah.
So our biopsy somehow showed that there were interlobular and peribronchial fibrosis with mixed infiltrates. However, the stranger thing was that they reported that few atypical cells have been seen, which are arranged in a glandular architecture. However, they got depleted in the deeper sections, and again, this biopsy was sent outside. So pathologists reported it as ILD slash possibility of malignancy, and they advised us to go ahead with.
Can muted?
Okay. No, ma'am. Am I audible?
Yeah, now.
Okay. So in the previous comment, what I was saying was that our cryobiopsy showed few atypical cells to the pathologist.
Yep.
And that was something which we were not prepared for. And they gave us they advised us for a repeat biopsy if feasible. So this is the PET CT that we have already discussed. And among spirometry, he has a restrictive one and with a severely reduced DLCO and desaturating as well.
Yep.
So the question to the panel was, I have modified it a bit. That is a repeat biopsy actually needed in such a case?
Actually, could we go back to the lung functions? That's a remarkably well-preserved TLC, isn't it?
Yes, sir.
Yeah, sorry. Go ahead, please.
And how you did the NFC? Which
So our
which method?
dermatologists usually do it with a dermatoscope.
Dermatoscope is a little inferior. Sometimes we may overdiagnose or miss. It's not easy to see with dermatoscope. But if you're finding similar dropouts in all the fingers, then it can be significant. But you have mentioned only in one finger, no?
No, that was decrement in the capillary density in one finger. However, tortuous vessels were seen in almost all.
And dropout also in all.
Yeah.
Prakar, can you just elaborate the long form of NFC for our audience and
nail
how
fold,
often you use it?
so it's nail fold capillaroscopy. And recently we have started doing it since we started a research over it over a year back, 2 years back. So presently, whosoever patients where we suspect that there is a possibility of a connective tissue disorder or a vasculitis, we usually go ahead with that. However, NFC changes have been seen in all form of fibrotic ILDs as well, including IPF.
And Mithun, you were saying it shouldn't be done with a dermatoscope?
Yes, sir. There's a nail fold capilloscope specifically for this, looking the nail fold. That's the ideal. Usual nail fold capilloscope is very costly, comes around 4 to 6 lakhs.
Oh.
But less costly things are there, like 50,000, and even cheaper, like 10,000. We are using the cheaper one, 10,000 thing.
Okay.
Yeah. But see, if only based on nail fold capilloscopy, it is difficult to diagnose any clinical condition. It is very useful, especially if you have a Raynaud's phenomenon, or if you have what you call ANA positivity. We can otherwise just nail fold capillary dropout. Dropout is classically seen with systemic sclerosis in among CTDs.
True.
Therefore, if you have to look for other features of scleroderma also. Is there ANA positivity?
No,
ANA
sir.
is negative, no?
It's negative.
And any clinical features of scleroderma, like any
No, sir.
vitiligo, like patches, or nothing, no?
Nothing.
Sometimes scleroderma may not have the typical skin tightening. They will only have the salt and pepper hyperpigmentation. Usually we have to go and see behind the pinna or scalp.
Yes, sir. We tried to look into that as well as we got the rheumatology review for the patient. So as per them as well, there has been clinical feature for the connected tissues.
Okay.
So,
I'm sorry, what do you mean by drop off of capillaries? I mean, what does it mean? I mean, what you're looking for exactly? Drop off of?
Dropout means that in nail fold, there are the capillaries, there is a specific density of capillaries will be there. If capillaries are lost due to some ischemia, then the number of capillaries will be less. That is called capillary dropout.
All right. Okay. Understood. Thank you.
So, sir, my primary question and ma'am, my primary question to the panel was based upon this CT.
Can I talk?
Yes, sir.
Your question is whether we should do repeat biopsy or not. Okay.
True.
So you have done a cryo biopsy, right?
Yes, sir.
So you are happy with the tissue sample.
We are.
So then instead of asking a repeat biopsy, because he is a heavy smoker, and suppose we think about say some sort of a alveolar cell carcinoma, which will never be picked up on PET scan. Okay. So if you can do the molecular markers directly, can it help? Just I'm asking you to confirm the diagnosis. I'm also not very sure, but I was just giving a thought whether nowadays they do directly molecular markers to diagnose a confirmed diagnosis of malignancy. So can this be a possible? You just discuss with your the pathologists or oncopathologist over there whether in such conditions where can we get a diagnosis, or if you instead of doing a whole biopsy again, a good lavage from a particular segment can probably make you in some malignant cells which can be studied for the markers directly, and it will I mean reduce the cost of again a biopsy.
Sure, sir.
So you're saying do molecular markers on
Direct
those
molecular
atypical
markers
cells?
on the tissue. Yeah.
On the
If the tissue is adequate.
That's actually a very good point, I think, Dr. Prahlad. I mean, the other description was that, the malignant cells get depleted as you go deeper. So, I think probably a BAL, a washing will probably give us some idea, and doing the markers directly makes a lot of sense. We can never forget that, you do a biopsy, it carries its own risk, including an exacerbation. So precipitating an exacerbation. So I think this should be the first approach
And
before
based on the
a
data we
second.
have on,
Can I?
Any
and based on
ILD
the
would
data
have
we have on cryo, I think Murli, probably about 10 to 15% of patients get reclassified, right? After a surgical biopsy post cryo. Bhavin, do you feel there's any sense of malignancy here?
So I'm not seeing anything, and more importantly, just carrying on Prahlad's argument, tumor markers, and because we do biopsies for sometimes, the oncologist sends a patient for a biopsy only to get material for tumor markers because it was inadequate the first time. The tumor marker positivity and the molecular genetics depends upon the concentration of tumor cells per cubic millimeter. Now, if you already don't have tumor cells in the sample, which the pathologist cannot see, so when you send the sample to the molecular guys, they actually look at the histopath to see if there are enough tumor cells. Only if there are, do they process for NGS, etc. So if you're not seeing tumor cells on the histopath, then the tumor markers are not going to be positive. So you can do a blood, what they call a virtual
Liquid
blood
biopsy.
liquid biopsy,
liquid
but that is horrendously expensive. I think it's about 3 lakhs to do a liquid biopsy in blood. So you might as well not, bother about that. The um, thing is, when I'm looking at the scans, really, I don't find even the slightest indication of any asymmetry that would be suggestive of malignancy. Can that rule out a very subtle early malignancy? Obviously not. I mean, it can still be there. But I just, this guy is really bad otherwise. And this all seems to be a smoking related situation. Maybe there's an acute exacerbation in terms of a DIP and, which occurs in these patients if they are current smokers, etc. So just wondering if that's just become a mixed picture because of that, so.
Only one thing is that Bhavin, the heavy smoker, smoking related lung disease, probably mixed. His lung function would have been much more worse compared to whatever he has shown.
Right.
But alveolar cell carcinoma, you can have a good lung functions also.
But the eye. Let's just run through the scan just to get that little clarity in. Okay, so upper lobe disease, all this is ILD. I mean, if at all we're looking at malignancy, it's somewhere in this area where you have this cystic change, this little increased density here,
Where did you do biopsy
etc.
from, Prakhar?
From the right lower lobe, ma'am.
Yeah, and
Oh,
and
okay.
that was between the two scans, correct? So this could also be post cryo change anyway. But we see invasive mucinous adenocarcinomas all the time, and to think that this pattern, the entire pattern is IMA is extremely unusual because it all fits into smoking related ILD. But I can't explain the PFT, so I don't know. I guess we're a little lost in that sense.
So, I mean, the very
Uh,
fact that he's a very heavy smoker increases the risk of having a malignancy.
Malignancy, yeah.
And they've also described that, the number of atypical cells are fairly sparse. So it doesn't surprise me that we're not seeing overt evidence of it. The point is a repeat biopsy now going to show us anything? And is it going to make a difference in his management? I suspect not. I think what you need to do is aggressively treat his smoking related ILD, see what you're left with. If things are growing, because he's certainly not a candidate for surgery or anything, then you could probably wait 3 months and then repeat an imaging and consider a biopsy at that stage. In the meantime, I would agree with Dr. Prahlad, we should go ahead and see even those few cells if they're giving us any markers or not.
Sure, sir. Thank you so much for your advice. I'll try to talk to my pathologist if they can work upon it. And
Yeah, I would also agree with Dr. Murali. I think even giving a short course of steroids, I mean, and then repeating the scan, because I mean, sometimes we know that I mean, smoking cessation might not be really kind of practical in this situation because he's with addiction and everything. But short course of steroids, I don't think it will do harm, even if it is alveolar cell. So short course of steroids and repeating the CT would be kind of more. I feel that it is appropriate, as Dr. Murali said. I mean,
but he's 57, right?
Yes, sir.
Prakhar.
Yes, sir.
Yeah, so he's not very old, and you just, I think with that pathology sign off, you don't want to miss a malignancy for sure.
Definitely, sir.
I understand where you're coming from. Yeah, that's true.
So coming to the, shall I start for the second case?
Yeah.
For the second case, there's a disclaimer that I have already discussed this with Asmita ma'am, and I thank her and her team for assisting me in this case. So she's a 62-year-old female who was a farmer and had significant biomass exposure. She was a known hypertensive on treatment with telmisartan since last 2 years. And now she had presented to us with shortness of breath, which had increased since 1 month. However, it was present since 1 year, and dry cough since 1 year. Am I audible? Yes. So these were symptoms. On detailed history, she had significant exposure to mold. Among connective tissue symptoms, she just said that some amount of vague dry eyes since last 3 months, and no other CTD symptoms and no systemic symptoms. She again was hypoxic, requiring 4 liters to achieve 92%, and no clubbing was present on examination of respiratory, bilateral, basilar fine crepitations. Among labs, her rest of the investigations were fine. ANA, ENA, everything was negative. PR3, we sent an ANCA as well. So PR3 came negative. NPO by IFA came positive. However, later on, advised by rheumatology, we did it with ELISA, and it turned out to be negative. Her HP panel showed positivity for penicillium as well as aspergillus, and she was exposed to the mold as per the history. NFC again, minimally dilated capillaries, and Shermer's, as she had complaint of dry eyes, was slightly low, 6 millimeter in the right eye as well as in the left eye with 7 millimeters. In the previous labs, her CRP and ESR were within limits, normal limits. We did a BAL based upon her radiology that we had. So that BAL was done in view of that she might be having some amount of diffuse alveolar hemorrhage. However, there was no evidence during bronchoscopy. And the BAL did not reveal to us anything. The TLC was just about 10 cells, 100% lymphocytic. If we can have these are her old CT scans. We do not have DICOM for them. These were just plates, so we took images. This was of May 24th. A lot of reticulations that we could see. Since May to December, till this time, she was on corticosteroids from 20 mg starting to 5 mg. And this is of December 24, when she started having aggravated symptoms. So as per our interpretation, the reticular pattern had reduced a little, but GGOs have definitely incremented. And rest, we have few DICOMs.
I think if we look at, we've got 2 scans about 8 days apart, 13th Jan and 21st Jan. And now that we've seen that she's had a pre-existing ILD, which was a non-UIP, non-IPF pattern, life becomes a little simpler because then, at least at that stage, we wouldn't have, it was kind of an indeterminate /HP/ whatever. Now, this whole ground glass pattern that we see is just acute exacerbation. I mean, we also see that background fibrosis. We see whatever is at the periphery, the honeycombing, etc. But whatever was in the center, which we saw in those images, is obviously now hidden by the acute exacerbation. And we see a little bit of upper lobe disease again at the periphery. There is no ancillary finding anywhere else. And then 8 days apart, there is no significant change in the extent of the acute exacerbation /inflammation / whatever. The CTPA doesn't show any evidence of thromboembolism, so that's pretty much out. And that's it. So it's really right now an acute exacerbation superimposed on a pre-existing non-UIP, non-IPF indeterminate ILD.
True, sir. And so in between these two imaging that we saw, since the patient was deteriorating, we had started her on pulse methylprednisolone for 3 days, followed by 1 mg per kg of infusion. However, even after this, there was no major improvement, as we can see in the CT as well, and her respiratory support had to be escalated to HFNO, alternating with an IV CPAP. Then I was stuck, so I had to discuss it with Asmita ma'am and her team. So there was a suspect that a myositis might be possible for this presentation. And while her myositis panel was awaited, ma'am advised to start her on tofacitinib along with Dr. Murli. And after approximately 3 days of tofacitinib, still there was no significant improvement. And on the same day, as we discussed the case, we got this LIA of our myositis panel, which is showing that SAE1 was positive.
Actually,
So-
Mithun was the one who
Oh,
helped
sorry,
us out.
sorry.
Yeah.
Yes, Mithun,
So
sir.
Mithun, yeah, you can see this particular. Do you think this is significant? SAE1.
Yes, it's definitely significant, and we thought it could be MDFI.
Even before the report, we discussed and we felt that the only disease which does not improve in spite of given enough steroids and background of CTD has to be something like that. And that is why and there was no harm other than Mithun told that there will be significant immunocompromise after starting tofacitinib. But Prakhar told that patient is on maximum, and I think you were giving Cepran, Meropenem and everything, right? Yeah.
Yes.
So, and pulse didn't work. And with this report, we started tofacitinib. And then afterwards, what happened, he will tell. Yeah.
Oh, pneumomidostene also. Okay.
Yeah, he had. Yeah.
Usually, pneumomidostene we see in MDFI.
Yeah, I
Apart
told
from
him.
COVID,
Yeah.
apart from COVID, I think they all behave like COVID, rapidly progressive ILDs.
And some
This
anti-synthetase.
pneumomidostene could have been due to the Macklin effect that we usually see in rapidly breathing patients, I suppose.
Yeah. But it no, what Mithun is trying to say is in particularly ILDs, the commonest causes are this, which we have come across. He's not telling that it is the reason.
Yeah.
He's telling that mostly it happens in those patients because I told you, our patient
Yes,
which
ma'am.
we had, I told you even before she developed pneumomediastinum, I told patient might develop this. So
True.
because it's very, very common things which we come across. Yeah.
Is the patient still alive?
Sir,
I don't know. Yeah.
No, the patient took LAMA and
Yeah, because
they took
we tried
and
to
you
call her actually twice, thrice, but they are not picking up the calls. So I suppose they have
Very unlikely to survive.
unlikely, because
Unlikely,
I don't think they
because-
could afford transplant if they couldn't afford all this.
No,
you know.
no,
No,
sir,
they were not.
at all.
I think Prakhar was arranging for immunoglobulins and all. He took
Yes,
lots of
morning.
time, and yeah, I think I discussed once with Dr. Shenoy also because we were just running short of time and we didn't have anything. So he was asking about plasmapheresis and all, and then I told, okay, let us see another opinion because how frequently you had seen SAE positive and
Yeah.
RPILD, Mithun?
Yeah, that was
We
just
have
going to
not
ask
seen,
Mithun that
yeah.
question. That was just...
I have seen dermatomyositis ILD SAE, but this type of pneumomidostene RPILD I have not seen.
So that is what even Shenoy asked that, are you sure this is PMDM related? And then we actually, I forwarded that article to Prakhar also, and we could
Yes,
find
ma'am.
one article in which it was predominantly cardiomyopathy related progression and patients are coming in that case also.
but cardiomyopathy progression, the pro-BNP would be elevated. And
Yeah,
I'm sure
but this
that would have
patient
been
didn't have.
done.
Yeah,
So.
this patient didn't
Hey,
have.
Prakhar, sorry, you had a bronch, right?
Yes.
No, sir, we could not do a bronch.
So
we did
You
a
did
bronch
na?
earlier when
Earlier, yeah, when she came.
No, but not at the time of the acute exacerbation.
No, sir, during the after the first scan.
You did. No? And so
Yes, sir.
there's no PCP, CMB and all
No,
that,
sir.
right?
Yeah, it was rolled out. Yeah.
That was actually I was thinking whether we could rule up PCP.
The virals were
Because-
negative, bacterial fungals were negative.
Everything was rolled out, and patient was on Cepran and Meropenem and everything, and still she
So
was not
that, what is
improving.
that? Beta-D-glucan, right? Is that
Beta
I'm
D
wondering
glucan.
whether
Yeah.
it would have been
all
worth
negative?
empirically starting PCP treatment. Back to the wall. You have nothing to gain. You've done everything else. So whether we
Nothing
should
to
have given her
lose.
that. But I
Yeah.
agree. Yeah.
No, the
You mean
only
nothing to
reason we
lose,
want,
not
yeah,
nothing to
we
gain.
wanted to discuss this was it's not always MDA5, which is the like you
Sure.
have to have open mind that
Yeah.
SAE positivity. Well, myositis itself is really not a good disease. Yeah.
We've been just seeing this spate of rapidly progressive ILDs in the
Mhm.
last few months. I don't know, Prahlad, Murli, have you also noticed this?
Or maybe we diagnose more.
Or maybe it's referral bias,
That's
I don't know,
it.
but it's
Yeah.
It's referral bias. Yeah. We're just
Yeah.
getting better at what we do. Yeah.
And we
We've
have
been doing this
started
for 30
sending. Yeah.
years now.
Yeah, we can't see it more. We
Yeah.
have
30
started
years
changing our
in and
practice.
out. I mean, Prahlad's been doing this longer than us, than
Yeah,
than
it's
me, than
probably
Sujit.
that.
I mean, think about it. Yeah. 91, we started looking at ILDs. Today, it's 2025.
Correct. Correct.
Not funny. So,
Yeah,
and
yeah.
we're still learning new things. So
Yeah, I know.
today I read an article. Can somebody throw some light on it? They said if you want to know whether an ILA is going to progress to ILD, do serum surfactant levels in adults. Is that something that has
Somebody
anyone's
told me
ever done?
serum KL6 also, sir.
No, but KL6 is
No,
not specific. No,
it's
surfactant
not
levels are
specific. Yeah.
specific. So if your surfactant levels are high,
Mhm.
chances are that ILA is going to progress to a fibrotic ILD. I'll share the paper. It just
Sure.
got published 2 days ago.
Mm.
And
Very
is that
interesting.
something anyone's ever done? Do we do surfactant levels?
No, we
Adult
do.
surfactant?
We
Surfactant
do
gene
genetic, yeah,
mutations, we
SPN,
do,
yeah,
but
That's
not
different. But this
yeah.
is, imagine. So now suddenly there's this new damn thing.
Mm.
Gosh. No, we must look at that article there.
I'll just mail it across to everybody. I'll send it to Asmita. She can send it to everybody.
Yes,
So.
please.
We
Yeah.
learn from our CT radiologists as much as our chest physicians.
Yeah. No, this
Let's
case
more
was
from our radiologist.
required because we felt that it will be a message because Prakhar also told Madam any point of discussing this case. Now we have already done
No, it
what
was
we
a good
wanted to.
case.
Yeah,
It's
because
learning. It's
I
wonderful.
insisted we should do that because we all deal with it. We all burn our hands in dermatomyositis.
Asmita, we can actually stop and say that we finished in time. It's just 3 minutes
Yeah,
over
but
time.
Yes.
but no. I think sir wants to. Rajan sir has
I'm
not
going to
sent me
ask
the
No,
email.
no, 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 no,
But I'd like to
Next
thank
time.
Next time.
Asmita ma'am, Dr. Mithun and Dr. Shinoy for assisting me, helping me a lot.
Yeah,
Ma'am
definitely.
spent, and I think ma'am was sending me case reports and mails even at the night. To
I
12 in the night.
That's where her week went, no, Asmita?
Asmita,
That
can I
all
just
that.
take you back to your case? You know, you
Yes, sir.
mentioned he had Zika symptoms.
Oh,
Yes, I was wondering because Zika is known to be associated with pulmonary hypertension.
okay.
But the panel was negative, I think, wasn't it, Dr. Mithun?
Yeah,
Negative,
it came negative. Yeah, it came
Does
negative.
it rule out Sjogren's or is it still worth doing the other tests for Sjogren's? A lip biopsy and Sherman's things.
Antibody will be positive in only 60 to 70% of Sjogren's syndrome. If you have strongly suspecting Sjogren, we have to do a lip biopsy.
I will send to Mithun. Yeah, I'll send across and you just examine and if you see what's doing and I'll do a proper echo also from a.
So, Dr. Mithun, I have one more question about the same case. And the reason to start on tofacitinib, I know that there are some case studies and case series are there over rituximab and cyclophosphamide. What is the particular reason that you choose tofacitinib over rituximab in this case, or maybe cyclo? Is there any particular reason? Because the evidence is very poor for tofacitinib. There are some case series are there, and it's oral, and I know that it's very easy to administer, but evidence base is I feel it is not
less.
strong.
It's largely case reports. I
This
agree
case
with
reports,
you.
I'm just asking whether you have any personal experience because I always have this doubt.
We had a personal experience, MDF RPI. Actually, most of our patients die despite all aggressive cyclophosphamide, cyclosporin. And there was a case series of from China, I think. They tried rituximab with tofacitinib. I think all the patients survived as per their.
And our patient also survived.
Our patient, I gave tofacitinib plus rituximab. and that patient actually survived.
Yeah,
But
she was also
however,
equally bad. Yeah.
but next patient, we did the same regime. That patient, we could not survive. I don't know
No,
whether
we
this
thought about
this
Amila.
is not the answer, but
Yeah,
in
Amila,
some
we
patients,
No, but
didn't
I-
give rituximab because Mithun told that it won't be active response, like immediate response you want, it won't happen with rituximab.
the very high dose steroids, Tofa and rituximab, very high degree of immunosuppression, and infection is the biggest risk. All sort of infections, viral, fungal.
Yeah.
But I
Unless
must
you
say
are
that,
sure.
yeah,
Yes,
the rheumats are very, very aggressive. I mean, so Sujit, I don't know if this patient's come to you, but Sanjeev Amin had a patient rapidly progressive. In 3 months, the thing's gone haywire, and it's rapidly progressive fibrotic ILD, which is your big thing that it's going to turn out to be myositis.
Right.
He's not even waited to investigate further. Straight away rituximab from the day he read the report, and then he's going to further figure out what
Escalate.
is to be done. This is
Yeah,
Sanjeev
yeah.
Amin. So,
Yeah.
I think this is where this must be coming from all these case reports and
Yeah,
studies
yeah.
and interactions saying that, first treat, then we'll see what it is.
Yeah, the final message which Shenoy sent me, which I sent to Prokhar, which he's telling in the middle of night, kind of. He was like, give cyclo, give
Whatever you have.
give plasmapheresis, do plasmapheresis, give cyclo, and whatever you
Whatever
can
it
do.
takes.
Yeah, whatever it takes.
Yeah, but you
It is
have
acute
to
condition,
balance the side effects and cost of all these
No,
treatments. I
they
mean,
could not
there's
afford
quite
anything, sir. Yeah, immunoglobulins and
I
very
also would
expensive.
like to contribute. There's a good acute conditions. Yes, rituximab really shows some good improvement. Similarly, in the chronic cases, instead of mycophenolate, tacrolimus also is a better drug. It acts very
Yeah.
fast compared to the.
So in CTD, ILD Prahlad, basically tacrolimus and tocilizumab, there is a slightly larger evidence base than tofacitinib, but
Yes.
there is increasing use, as Mithun was saying. There are series.
in myositis,
Yes.
myositis especially. Yeah.
And ease of use and not expensive also. Like
Now
Correct.
that's not expensive.
Which is why probably Prakhar's team was considering that for this patient. Yeah.
You don't have case, Rajan sir?
No. I have some more data on that patient coming, so
Sure,
we'll do
sure.
it next
So-
time. And
so
I
yeah,
also
they
want to give a
definitely-
follow-up on the patient with a family history from
Yeah.
both sides.
To
when
the
we come
panel,
next
if I
time.
may ask, God forbid if we encounter similar case in future, what should be our take? We can understand that the financial issue may exist most of the times. So
Oh.
if we are looking after all the drugs that we can give, once it comes down to give whatever you have, what should be our best choice of that we can at least advise to the patient? Would it be Rituxi? Would it be
I definitely
tocilizumab?
don't think Prakhar carpet bombing is going to help them financially. So you would go one thing at a time, but I'd probably also defer to Prahlad, Murli, and Mithun on what they think here. But we have started usually with plasma exchange in such patients.
Okay.
What do you all feel?
Plasma exchange is a very good option because initially the immediate effect you can get, like plasma exchange or IVIG, and there's an increased risk of infection also.
Sure.
But plasma exchange, you should have those facilities.
Yeah.
Okay.
And
But
Prahlad?
with IVIG, you don't have that great a risk of infection. So sometimes
yes. IVIG, upfront IVIG with rituximab.
Just I would like to ask. Yeah, I think plasma action will be better, but tofacitinib, how much time it take for a action to happen actually?
24 to 48 hours.
Oh, with that 5 milligram BD we can get.
Yeah.
Okay. Thank you.
Thank you.
Okay.
Thank you for your.
Okay. Thank you so much. And
Thank you.
yeah,
Thanks,
for a change, we
everyone.
finished on time. So
Thank you.
sir is
10
happy.
minutes late, it's okay, not too bad.
When is the
Anyway,
next
the
meeting, Asmita?
next meeting is on 7th February. We are going to meet on 7th February and it
Which
will
is
be
next Friday.
yes,
Next
the
Friday.
next Friday, and Marvin sir is going to be there, and I hope
We
everybody.
finish a year apparently, and
Yeah,
she
we
wants to
finished one.
felicitate everybody, and we'll
Yeah.
felicitate you.
Oh,
So
online,
yeah.
online,
So
because I think it is good to finish, sir. Nobody predicted that we will do, right? When we started,
that's
it was
true.
nothing.
That's
Yeah.
true. That's true.
So that's why. Anyway,
Good fun.
thank you so
Thank
much.
you.
Yeah.
Thank you.
Thanks.
Yeah.
Take care. Bye bye.
Thank you so much.
thanks everyone. Bye.
Bye. Bye.